Hello, I'm Davida Kruger. I'm a certified nurse practitioner at Henry Ford Health, Division of Endocrinology, Diabetes, Bone and Mineral Disease. I'm here to talk to you today about what primary care clinicians need to know about once weekly insulins. This presentation is sponsored by the Illinois Academy of Family Physicians and Primary Care Education Consortium and supported by an educational grant from Novo Nordisk Inc. PCMA, the Primary Care Metabolic Group, is also part of this in collaboration, and you can join this group to get other CME credits, discounts on conferences, and resources for clinicians interested in metabolic disorders. Please feel free to register right now. And for your CME information, the AAFP has reviewed what primary care clinicians need to know about once-weekly insulins and deemed it acceptable for up to one enduring material self-study AFP prescribed credit. Term of approval is July 1st, 2024 to June 30th, 2025. Physicians should claim only the credit commensurated with extent of their participation in this activity. Following the CME activity, participants will have the opportunity to earn additional 2 prescribed credits for participation in each translation to practice exercise, and I'll explain that to you in a minute. Information on translation to practice will be shared within the activity. Here we are. What is translation to practice credit? Well, you may qualify for an additional 2 credits if you make a commitment to change your practice. We're not asking a lot. We just want to know that you heard what I said today, you've taken that home with you, and you've made some behavioral change within your practice. You'll receive a post-practice presentation survey, and the survey you'll be asked to commit to changes in your practice behaviors, to specify what those changes are, and you'll have to provide us your name and email address so we know where to send the credits. If you do not enter the required data mentioned above, you'll not be eligible for the T2P credit. So please, 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 please include all of the information. Approximately 6 weeks later, you will be contacted asking if those changes were made, along with some additional questions. If you've completed those changes, you're eligible to complete the survey and generate a certificate for the additional credits. So please feel free to commit to the changes, specify what you think you are going to do in your practice, and provide us your name and email address. And then 6 weeks, you'll have a chance to make those changes in your practice, report them back to us when we ask, and then you'll get your certificate for the additional 2 credits. And then the American Academy of Nurse Practitioner Certification Program and the American Nurse Credentialing Center accept AAFP prescribed credit and AMA PRA credit category 1 credit. So you'll also be able to get credits for this. In terms of faculty disclosure, the Primary Care Education Consortium adheres to the conflict of interest policy of the ACCME and the AMA. It is a policy of PCES to ensure balance, independence, objectivity, and scientific rigor in all its educational activities. All individuals in a position to control the content in our programs are expected to disclose any relationships they have had with commercial companies whose products or services may be mentioned so that participants may evaluate the objectivity of the presentations. In addition, any discussion of off-label, experimental, or investigational use of drugs or devices will be disclosed by the faculty. Only those participants who have no conflict of interest or agree to identified resolution process prior to the participation were involved in this CME practice, and here are our disclosures. All right, so let's get started. I have a lot to share with you today, and this is a very exciting new topic. So our learning objectives are to participate in this activity. You should be able, at the end of this activity, you should be able to Initiate basal insulin therapy without unnecessary delays for patients with type 2 diabetes who it's indicated for insulin treatment. Review the clinical efficacy and safety data for new and emerging ultra-long-acting once-weekly insulins, and then compare and contrast the potential benefits and risks of once-weekly insulin compared to our traditional basal insulins. With a little introduction, we will get started. So type 2 diabetes is a serious public health concern globally and certainly within the United States, associated with significant morbidity due to microvascular and macrovascular complications resulting from elevated blood glucose and diminished function capacity, lower quality of life, and premature death. What we know is 1 in 10 Americans have diabetes. Most have type 2 diabetes. And here's another fact. About 1.2 million people are diagnosed annually. Again, mostly type 2 diabetes. Well, what about the primary care clinician's role? Well, primary care clinicians treat most patients in the U.S. who have type 2 diabetes. I'm in an endo practice. We get some patients with type 2 diabetes, but we know the majority are in the hands of the primary care clinician. And you're often the first clinician to actually diagnose type 2 diabetes. Some patients may come to our clinics that have type 2 diabetes and see an endocrinologist. However, projections indicate current and future shortages of endocrinologists. We just do not have enough that are practicing in the world of endocrinology can manage that many people with diabetes. And so the majority of them fall on the role in the hands of the primary care clinician. 90% of patients with type 2 diabetes are treated by the PCC, and the PCC plays a critical role in the management of patients with type 2 diabetes, which often involves the start and use of basal insulins. So let's talk a little bit about basal insulin in T2D. Insulin is still an essential and effective glucose-lowering treatment for many patients. We know about the advances in molecular biology and drug delivery technologies seen in recent years. And the goal of insulin therapy is to replicate as closely as possible a normal glycemic profile without any unacceptable weight gain or hypoglycemia. And you know the two things patients hate the most is weight gain and the fear of hypoglycemia. So for patients with T2D, initiating insulin therapy should start with basal insulin with a preference for basal insulin analogs. They're the most like what the body's not making. And the ADA recommendations have changed over the last couple of years as other medications emerge, and they want you to consider as the first injectable therapy when a patient's blood sugar is greater than or equal to 300 milligrams per deciliter, A1C is greater than 10%, there's symptomatic hyperglycemia or signs of catabolism due to glucose toxicity. You meet that patient, they fall into these categories of 300 milligrams blood glucose, A1C is greater than 10, symptomatic hyperglycemia, catabolic state. That's somebody that you're going to give insulin to right away. And then you're going to meet other patients who have other therapies that those therapies are not working to where they should be. They're going to need a basal insulin as well. But here's our problem. This is NHANES data. And if I took you back to before 2023, I promise you the numbers don't look better. And it's unfortunate with all the other therapies we now have, including continuous glucose monitoring, GLP-1s, SGLT2 inhibitors, we're not doing any better. And many of our patients should be moved to a basal insulin. So many patients with type 2 diabetes do not achieve glycemic control. If they're not achieving glycemic control, we have set them up for failure in many ways, mostly in complications related to type 2 diabetes. Fewer achieve the simultaneous control of associated cardiovascular risk factors. 5.8% of these patients do not reach target A1C. That's almost 60% of these patients do not reach target goals. 17.3% patients reach targets for composite of A1C, blood pressure, and lipids. Only 17.3%. All of our patients have elevated blood pressures. They have elevated lipids. They have elevated A1C. They have type 2 diabetes. And we're only achieving that in 17.3%. And then less than 10% of our patients reach targets for composites of A1C, blood pressure, lipids, and BMI. We have to do better for people with diabetes. So what is the patient's perspective on insulin? Some of that I think is how we present it to the patient, but it's still very burdensome to the patient. Thinking about daily injections, hypoglycemia, weight gain, changing nutrition, 1,000 different things of diabetes to stress. So acceptability of insulin is low among patients with type 2 diabetes, and it leads to reluctance to initiate. And more importantly, if we get them to initiate, continued insulin therapy. And a large proportion of patients interrupt or discontinue treatment shortly after initiation. It's the patient I've had who I start them on insulin. I think I'm making progress. I thought they heard me. I call them up in a week's time. How's it going? And they go, I didn't want to do that. So I threw it away when I walked out the door. Heart failure. Obviously, my conversation was off. That patient really needs to be on insulin, and we need to find better ways, less complex for those individuals. So 7.4 million Americans use one or more form of insulin to manage diabetes, yet only about 20% of the patients initiating basal insulin continue with insulin treatment within the year after initiation. The patients we put on insulin need to be on insulin, and if only 20% continue, again, we've not done our job. But what about clinical inertia once we get patients on insulin? So there's clinical inertia, lack of treatment initiation or intensification, resulting in failure to achieve glycemic goals. Clinical inertia in the U.S., common reason for poor glycemic control. This part's on us as the clinician. Fewer than 50% of patients with type 2 diabetes and a high A1C had their treatment appropriately intensified, and has seen more than 26% of patients who had A1Cs greater than or equal to 7%, and more than 18% of patients with A1Cs greater than or equal to 8%. Those patients also failed to have intensification of medications after a median follow-up of 4.2 years. So very few people are making treatment goals, and those that aren't, we're just not making the adjustments the patient need. Sometimes we say, well, 8% is good enough. It's not good enough for people with diabetes. So inadequate glycemic control in 40 to 60% of patients with type 2 diabetes. So in this retrospective cohort study of over 80,000 patients, the median time to intensification with insulin was longer than 7 years for those not achieving glycemic goals on oral therapies. Now, I'm in clinical practice. I get what happens. The patient comes in and they say, give me 3 more months, give me 3 more months, give me 3 more months. If they could have achieved that, they would have done it. And even if I start them on insulin and they're able to improve other aspects in their lives, they may need less insulin or they may come off of it. But at that moment in time, we're missing the mark. We're waiting too long. The patients don't come back in for follow-up. And you can see longer than 7 years for those not achieved glycemic goals. And that is really not acceptable. So study of clinical inertia in patients with type 2 diabetes in primary care practice. Clinicians waited an average of 9 years before initiation of insulin. The average A1C was 9.5%. And of course, by that time, complications were already present. We could have done better for those patients. And the other thing is, we need to explain to the patient the seriousness of their diabetes, that it's not their fault, and that insulin is actually their friend in terms of helping them get to treatment goal. Even after initiation, insulin was not titrated adequately, because I always say start insulin lower, go low, start slow so that you don't get hypoglycemia, titrate on a regular basis, work with that patient. But if we're not titrating, we're not going to get those patients to treatment goal. and the average A1C remained at 7.9 after 4 years of treatment. And anyone in the room thinks 7.9 is acceptable. It is not. It is better than 9.5, but it's still not acceptable. So the prevalence of clinical inertia is remarkable, considering the focus of guidelines. Doesn't matter whether you look at the American Heart Association, the American Diabetes Association, Endo Society, they're all telling you the importance of glycemic control, and increased attention is needed to achieve glycemic targets in patients with type 2 diabetes. New formulations of basal insulin, such as ultra long-acting once weekly, which is pretty exciting to me, are nearing FDA approval. Provided that patients' risks are properly addressed, once weekly basal insulin are predicted to increase treatment adherence. Very important. If I tell the patient to take an injection once a day, I guarantee you that when I see them at the next clinic visit and I very kindly ask, how often do you think you miss your basal insulin? Many, if not all, will say a couple times a week, if not more, and that's going to keep their A1C elevated. But if I give them once weekly, increased treatment adherence because it's once a week, decreased clinical inertia on our part, and improved patient quality of life. So here's a patient case scenario. 59-year-old woman with 20-year history of type 2 diabetes presents to her PCC for a follow-up visit 3 months after starting basal insulin once daily. Despite her hesitation to agree to an injectable medication, after 1 month of titrating her basal insulin, which was done via twice weekly phone appointments, she had reached 45 units of insulin glargine, which is about half a unit per kilogram. Fasting glucose ranges 130 to 140, and she was not having hypoglycemia. Since then, she says that she has a difficult time remembering to do her daily injections on her own. She also doesn't like having to give herself an injection every single day. So for adherence, daily injections are hard for this woman. She doesn't always remember it, and she doesn't like doing it. So today, her fasting blood sugar is 195, A1C is 9.6, which is an improvement from 10.3, but still we have a long way to go. She's on metformin 2,000 milligrams daily and oral semaglutide 14 milligrams daily. She states that she would like to try and work on her diet and exercise to get her A1C lower towards her goal of less than 8%. And you can do that in increments. She started at 10.3. She's now at 9.6. Next, we're going to try to get you under 8%. So what do you think? Is this patient at risk for clinical inertia? How might a once weekly basal insulin be helpful for this patient? So the patient originally responded well to basal insulin with fasting blood glucose values that indicate improvements in overall glucose control. After she was no longer under close follow-up, she began to miss doses, not uncommon. She's at risk for clinical inertia, raising her risk of complications that can result from hyperglycemia, and which really is unfortunate. We do have ways to prevent those complications. And this patient may be a good candidate for receiving a once-weekly basal insulin, assuming it's approved, to promote her adherence and overall glucose control, and due to her preference for fewer injections. Once weekly would certainly be exactly what this woman is talking about. So let's talk about the new and emerging once weekly insulins that hopefully will come to market soon. Their innovative insulin formulations and delivery systems have resulted in an expansion of choices that include basal insulin, rapid-acting insulins, and intermediate-acting insulin formulations. Those are the ones we're using today. A once-weekly basal insulin formulation are in late-stage development, with insulin Iodex receiving a recommendation for marketing approval in Europe and an FDA decision expected in third quarter of 2024. So now's the time for us to learn about them, so when they come to market, we're ready to use them. So insulin Iodex is a novel once-weekly basal insulin analog that has a prolonged half-life through strong reversible binding to albumin, reduced enzymatic degradation, and slow receptor-mediated clearance. The second weekly insulin is basal insulin FC or BIF, a novel once weekly long-acting IgG FC fusion protein. So on the left-hand side are the basal insulins that you're used to. NPH, insulin Degludec, insulin glargine U100, insulin glargine U300, and IDEC. These insulins are the ones we're using today, and some of them, like NPH, IDEC, actually have less than a 24-hour coverage, but your glargine and your IDEC are at least 24 hours. But you see they have a fairly strong peak at their onset. The dotted line is our new once weekly basal insulins. And look how exciting that is in terms of the flat excursion. So flatter pharmacokinetic profiles, reduce variability, reduce injection burden. And that's your weekly glucose profile. So let's talk a little bit about an overview of the weekly insulins that are in late stage trials. While once weekly insulins are not yet clinically available, evidence supports their comparable efficacy and safety in patients with type 2 diabetes. Insulin Iodex has been evaluated in 5 phase 3 randomized trials in patients with type 2 diabetes, and BIF is being evaluated in 4 phase 3 randomized trials in patients with type 2 diabetes, all of which are currently ongoing. But let me show you the data that is available. This is the phase 3 trials for insulin Iodex, onwards 1, 2, 3, 4, and 5. You can see some are open label, some are double blind. You can see the number of patients range from over 500 up to 1,000, and the comparators were glargine U100, Degludec, and glargine U300. And they could have had other insulin drugs on board, non-insulin drugs on board, basal insulin with non-insulin glucose lowering. So a multitude of other therapies that potentially could have been on board and the patient in need of basal insulin. Duration for the studies were 26 weeks to 78 weeks. Here's some of the results and hypoglycemic events in the onwards trials of insulin Iodex. So starting with onwards 1, which was compared to glargine, A1C reduction of 0.2%, increase in patients at A1C target without significant hypoglycemia, and time in range was increased by 4.3%. In terms of hypoglycemia, Iodex 227 episodes in 61 patients with 1 episode severe, glargine 114 in 66 patients with 7 episodes severe. So you'd expect hypoglycemia from these medications because they're insulin, and you can see in onwards 1, Iodex had less severe hypoglycemia than glargine. In onwards 2, Iodex demonstrated non-inferiority and superiority to Degludec in reducing A1C from baseline, and no significant differences in hypoglycemia. Onwards 3, Iodex compared to Degludec, A1C was 0.2%, an increase in patients at target A1C without significant hypoglycemia. And you can see that Iodex did not have any significant hypoglycemic events versus Degludec, which had 2 episodes of severe. Onward 4, A1C reduction in both of the treatment groups, and 35 episodes in 22 patients and 33 episodes in 25 patients, so similar hypoglycemic events. And finally, onward 5, in conjunction with the dosing guide app that will be available, demonstrated non-inferiority and superiority compared to basal insulin analogs in reducing the mean A1C, and no significant differences in hypoglycemic events. So what you're basically seeing is the hypoglycemic events occurred with less severe hypoglycemic events in the Iodex group, and then also noted is A1C reductions. And these are the 3 trials for the BIF in the type 2 diabetes. There are no, they're still ongoing, so I don't have any results for you, but you can see that they're being compared to glargine U100 and Degludec and they're 26 to 78 weeks, and they're all open label. So hopefully we'll have some results on these pretty soon. So looking to the future of once weekly insulin in clinical practice. So when we're preparing for weekly insulins, as once weekly insulin formulations become available, the PCCs will be at the forefront of providing practical strategies for integration of these formulas into clinical practice. Indications for once weekly insulins are likely to be similar to those once daily insulins. New insulin titration strategies will be needed because glucose lowering will not achieve a steady state for several weeks after initial dosing, and then clinicians and patients will need to learn these approaches and how to manage dosing and concomitant preprandial insulins. So there's a learning process that we're all going to be going through at the same time because the dosing will be higher because it's 7 days worth of insulin. So there'll be new titration strategies that we're all going to need to learn. We're also going to need to learn how it fits with the other medications that each of these patients are taking. And so the clinician and the patient will need to learn these new approaches, but the guidelines should be available for us as these do come to market. So what about potential patient selection for weekly insulins? If weekly insulins become approved and available, fingers crossed, not all patients may be appropriate candidates for this therapy. Patients with inadequate glucose control, despite multiple therapies and poor adherence to daily injections, may in fact benefit. So some of the examples of patients who may benefit from once weekly insulin if approved, think about patients with type 2 diabetes inadequately controlled on multiple glucose lowering agents who now require basal insulin therapy. They're probably an ideal person that we would think about. You want them to start insulin? We're just going to give you one injection a week. And then patients who prefer flexibility in dose timing and those who have difficulty with adherence to daily injections. Think about the patient who is missing injections several times a week. And as much as we talk about pick a time you're supposed to be taking your basal insulin, sometimes it's a huge gap from when they take it one day to the next day. And depending on which basal insulin they're taking, there may be a huge time when they're not getting basal insulin. So those are just two examples of patients you might consider for weekly insulin. So what about some benefits and concerns compared to once daily basal insulin? Once weekly basal insulin have a variety of potential benefits, including improved adherence and persistence, flexibility in the time of administration, reduced glycemic variability. I showed you that dotted line, nice and flat for the whole week for the patient taking this once weekly injection. They could pick their favorite day that they can remember to take their insulin. They put it on their calendar, they put it on their refrigerator, they put an alarm in their phone, but they only have to do it once a week. And that will drastically improve adherence and persistence for that patient. And then we'll have some flexibility in time and administration. And certainly with the profile I showed you, reduce glycemic variability. So potential concerns, and when any new product, we have to work through some of the concerns. It's a lack of familiarity, not just for primary care world, but it will be for the endos as well as we all learn this together. Challenges with dose calculations going from a U100 or a U300 basal to now using a once weekly. And then clinicians' concerns about hypoglycemia. All insulins have hypoglycemia. And I think I showed you clearly in the data that some of the hypoglycemia was a little bit more than the basal insulins we're using, but severe hypoglycemia was less. And hopefully that'll help us all feel less concerned about starting once weekly. What about potential benefits? Injection burden is a major barrier to insulin adherence. Fewer injections can reduce this burden and improve the likelihood of treatment adherence. When once weekly insulins reach steady state, a missed dose does not result in immediate loss of efficacy due to their long half-life. And due to a flattened pharmacokinetic profile of once weekly insulins, decrease in day-to-day glycemic variability is expected. So lower injection burden, improved convenience, adherence, and quality of life, increased flexibility in dosing timing, better glucose coverage in the case of a missed dose, and then decreased day-to-day glycemic variability. All of these things enhance the life of our patients. So what about potential concerns? Patients and clinicians may worry over a large dose of insulin injected at once, and how will that reflect in hypoglycemic management? Increased familiarity with weekly insulins may address these concerns. As with any insulin, hypoglycemia is a potential safety concern, and we need to talk with our patients about how to treat hypoglycemia. However, this medication does respond in the same way to other basal insulins when we're treating hypoglycemia. So lack of familiarity, challenges with dose calculations, and then concern about hypoglycemia may be our potential concerns. So a meta-analysis of 7 randomized trials looked at increased risk of hypoglycemic events with insulin iodex compared to once daily basal insulin. Numerically decreased risk of severe hypoglycemia was noted with insulin iodex compared to once daily basal insulin. And then managing hypoglycemia with insulin iodex, the fundamental principles are similar to treating typical hypoglycemia episodes, and insulin iodex has a similar counter-regulatory hormone response and recovery compared to insulin glargine. Patients need to always have something to treat hypoglycemia, any basal insulin, and when we prescribe insulin, we should also be prescribing glucagon. So let's go back to our patient case. Fasting blood glucose is 195, A1C 9.6, improved from 10.3 3 months ago, but not good enough. Also on metformin, oral semaglutide, and states that she would like to try and work on her diet and exercise to get the A1C lower towards her goal of less than 8%. And I really encourage you to refer a patient for diabetes education and certainly for medical nutritional therapy. And that is so helpful for a patient to understand what they're eating. And also my own personal comment would be, if we're prescribing insulin, we should also have the person on a continuous glucose monitor. So would this patient be a good candidate for once weekly? I think we'd all say yes. So revisiting the case scenario, use of a once weekly insulin would likely help the patient be more adherent to a regimen because she prefers to avoid daily injections. She's not telling us she won't take insulin. She started insulin. She's having problems with adherence. Let's help her along and give her a once weekly. With improved adherence to her basal insulin regimen, her blood glucose would likely improve, lowering her risk for cardiometabolic complications associated with hypoglycemia. And that's a given. Her A1C stays at 9.6. She will have cardiometabolic complications. Now let's look at another case study. Mr. A is a 56-year-old male. He works on the line at one of the auto industry plants. He was told he had type 2 diabetes about 6 years ago. A1C at that time was 8.8%, and he was started on metformin, 500 milligrams, and titrated to a maximum dose tolerated. GLP-1 weekly added 1 year ago, and presently he's taking 1,000 milligrams in the AM and 500 milligrams in the PM of metformin and 200 milligrams of semaglutide once weekly. It's not unusual for our patients not to be able to do 1,000 milligrams of metformin twice a day. They often don't tolerate that for the GI symptoms. And we also want to start slow with the metformin so you can figure out where the GI symptoms are. So he's on 1,500 milligrams of metformin and the maximum dose of injectable once weekly semaglutide. Labs include a fasting blood glucose of 242, an A1C of 8.2%. No referrals have been made for diabetes self-management education, DSME, to include medical nutritional therapy, MNT. And while I super believe in both of these, and it so helps the patient with diabetes adjust to their diagnosis and get questions answered, every patient should see a dietitian. None of us are able to, I think, really counsel patients in that area, and patients have no clue what's in their food. and how to make changes. And then no self-monitoring of blood glucose, SMBG, or continuous glucose monitoring, CGM, were instituted for this person. And so if you can't see the data, you can't treat the data. So the patient has no guidance in what to do. And we as healthcare providers have no guidance on what this patient needs without the benefit of something like CGM. He weighed 232 pounds. He's 5 feet 10, which gives him a BMI of 33.3. He was pretty physically active on his job, but once he gets home, he is not. And I heard a cardiologist say that inactivity is the new smoking in 2024. So working with patients on physical activity, not only because of the diabetes, but the cardiovascular risk is really important. History of hypertension, taking 40 milligrams of Cinepril. Blood pressure was fine on his last visit within normal limits. History of elevated lipids, arovastatin 40 milligrams. Recent LDL is 68, but a family history of type 2 diabetes, mother and one sibling. So this man has obesity, type 2 diabetes, elevated lipids, and hypertension. And based on his age, over 55, he is at high risk for complications related to diabetes. And we really do want to get his A1C under treatment goal. So A1C treatment goal for this person would be less than 7% with time and range greater than 70%. And we really want to avoid low blood sugar. So usually we're looking at less than 5%. The conversation had to be a need for basal insulin. He was referred for diabetes self-management education and MNT, talked about physical activity. I did place a professional continuous glucose monitor. We discussed potential benefits and side effects of insulin, prevention of hypoglycemia. We want to continue the metformin and the GLP-1. GLP-1 has so many more benefits beyond just just glucose control. And the combination of metformin, GLP-1, and insulin is a nice combination. Patient agrees to start insulin at 20 units daily, and we decide to give him his first injection in the office. I always try to do that so I can talk about technique, site rotation, whatever the questions or concerns. And usually getting that first injection is the hardest for patients. So we typically do the first one in the office. And then follow-up support for the patient to provide titration and education. The last thing I want to happen is this patient come back in 3 months and he's still on the same dose of insulin that we started him on, and we're not closer to the treatment goal, or we're not at the treatment goal. Here's the professional CGM. So if you look on the top left bar, you see that his time in range is 42%. Remember, I said our goal is greater than 70%, and his high glucoses are 58%. We want more green, less orange. On the right-hand side, his average glucose is 201. The GMI, now it's a GMI. A GMI is like an A1C, but it's for the period of time I'm looking at the CGM data. I'm looking at 2 weeks worth of data. And so the GMI for those 2 weeks is 8.1, but it's not far off from his A1C of 8.2. His coefficient of variance, we want it to be less than 36, and his is good, but it's not good. What do I mean by that? It's less than 36, but it's less than 36 in the high range. So that tells me he's taking the medications I have prescribed, but I'm not giving him enough because his average glucose and his A1C are way too high. Now come down to the ambulatory glucose profile. And what you're seeing is the 2 weeks worth of data, making it look like 24 hours superimposed, so my brain can wrap around all of this data and see where we need to go. So if you see the two thick green bars, that's your time in range of 70 to 180, and you can see that this person's time in range is way above the 70 to 180, and the goal would be to bring it down. That's our goal. So we need to add basal insulin. And we, of course, show this data to the patient so they understand. Again, remember, you need to see it to treat it, and also for the patient to have an understanding of why we want to do other therapy. And I don't go with, give me 3 more months, give me 3 more months. Why? Because if the patient could have done this on their own without giving them more medication, starting a basal insulin, they certainly would have. And so I want to start a basal insulin on this person because I want them to have a better outcome and less risk of complications. So why am I using professional CGM in this patient and in all patients that don't have their own continuous glucose monitoring? Professional CGM is a sensor that I purchase for use in my clinic. I place it on the patient as I meet them, or if they don't have their own personal CGM. It gives me data within 10 to 14 days that allows me to make good judgment on the next step in the phase of their insulin needs, their dosing, choices of medication. And in the instances of the cases today, I need data so that I can share that with the patient so they understand why I'm offering them a basal insulin, and also it helps me with dosing. Once I place that, I can then prescribe for these patients their own personal CGM. And typically, if a patient is on insulin, their insurance will in fact pay for personal CGM. They will also pay for me to place a professional CGM. So it's a win-win. I get data up front when I place professional CGM. I get the data right away. And then later on, I can order personal CGM so the patient can manage their diabetes better long term. So we're going to continue the metformin in the AM and 1,000 milligrams, 500 in the PM. The GLP-1s at the maximum dose, we're going to keep that. And we're going to give him glargine taken at 9 to 10 p.m. And he's now on 40 units of that basal insulin. So we were able to titrate it over the time. His A1C is 7.6, but the patient shares that he's doing his best to take insulin daily, but once or twice a week, he falls asleep and he forgets to take it. So A1Cs come down nicely, but it's not at treatment goal. And if I could get him to take all of the insulin prescribed, I promise you this A1C would be less than 7%. Once or twice a week is enough to keep that A1C almost 1% higher than what I want it to be. So would this patient be a good choice for a once weekly insulin? Absolutely. So what are the considerations for this patient? The patient we know is willing to take the insulin, but forgets to take the basal insulin 1 or 2 days a week. Increased adherence will improve the glucose outcome and decrease the risk of complications. I can get this patient to treatment goal most likely if he only had to take insulin, basal insulin once a week. Discuss the risk of hypoglycemia is important in the use of all insulin formulations, and discuss education, including MNT, and that'll help support the patient be successful in managing their type 2 diabetes. Ongoing education is always important. So who's the person who forgets or skips insulin dosing? This may be a problem with any of your patients who have diabetes who are treated with insulin. I see it every single day, and I always ask gently, without judgment, how often do you think you might miss your basal insulin? And then patients are much more comfortable telling me that it might be once or twice a week. And then if they say once or twice a week, my brain kind of thinks maybe it's more often. And then studies show that missed insulin doses are recorded for patients with type 1 and type 2 diabetes. And in both type 1 and type 2 diabetes, missing insulin doses is a problem that we need to find better ways of addressing. Once weekly insulins may be the answer. Okay, so here is case 3, a newly diagnosed patient, because in the primary care world, you're going to see the newly diagnosed type 2 person long before I see him in an endocrine practice. This is a 48-year-old woman who comes to your office with a complaint of thirst, weight loss, and frequent urination, recently treated for a yeast infection. That also tells me that those glucoses have been high for a while. She has a history of hypertension, elevated lipids, both well controlled, not unusual for us to see in our patients who have type 2 diabetes, and has family histories of type 2 diabetes, both mother and an aunt. And today, her blood glucose is 296 with an A1C of 10.4. What does that tell me right away? Well, the American Diabetes Association standards of care say if that A1C is greater than 10% or greater than 9% and symptomatic, you should consider a basal insulin right then, right there. This woman is symptomatic and her A1C is 10.4. I'm going to offer her a basal insulin, but I'm also going to place a professional CGM so that I can help her see what I'm thinking, seeing, doing, and get support and understanding. Again, you have to see it to treat it. All right, so this is her CGM. On the left-hand side in the upper box, you can see that she's only 7% time in range, 93% her blood sugars are high. No wonder she's thirsty, losing weight, and has a yeast infection. That will certainly do that for this woman. Her average glucose is 298. She has a GMI of 10.4, again consistent with the A1C. Coefficient of variance, I'm not even going to look at that today because all of her blood sugars are high. That means that she would have had a lower coefficient of variance. I want that coefficient of variance to be low with blood sugars between 70 and 180 time range. And I think that once we get this woman on a basal insulin, she will feel so much better. Okay, so based on the ADA standards, what therapy would I offer this patient? Absolutely. I'm going to give her metformin to a maximum dose tolerable, but metformin is only going to bring that A1C down maximum of 1%. That'll help me along the way, but that's not going to help this woman feel better, and she needs to feel better now. And so basal insulin, and again, when you look at a patient who's symptomatic, A1C is greater than 10%, the conversation should be basal insulin. They'll qualify for personal CGM. That'll help them in the guidance. That helps also with behavioral change so they can see what they eat, what activity, and how that relates to the use of their insulin. Again, this individual needs diabetes education to include MNT. Support to titrate the basal insulin because, again, I'm probably going to give this woman 20 units to start, but her A1C is 10.4. That's not enough to get her to an A1C of less than 7%. And I can think about other medications after I get the A1C down a little bit and she's not symptomatic, but today she needs basal insulin. So treatment goal should be A1C of less than 7% with greater than 7% time in range, and we want to avoid hypoglycemia of less than 5%. So would this patient benefit from a once weekly insulin? Absolutely. I'm telling her today she does not feel well. She's got hyperglycemia. I want to start her on insulin. And how much better would it be if I could say to you, you only need to do this once a week, not every single day. So what are the considerations for her? The same as everything I have said to you for patient number 2. But I also want you to think about how overwhelming the diagnosis of diabetes is and how complex it is. We're going to ask those patients to change eating habits, be more physical, maybe have them take metformin and take an injectable. And so if I can give that patient a once weekly, that's a win-win in terms of adherence, follow through, and helping that patient get to treatment goal. So what about a summary now? Let's revisit the knowledge question 2. Which of the following patients would likely be the best candidate to receive a once-weekly insulin? A, a 23-year-old man with newly diagnosed type 2 diabetes, A1C of 8.5. B, a 59-year-old woman with type 2 diabetes who takes basal insulin along with other glucose-lowering agents, is concerned about weight gain, and her A1C is at 7.1%. C, a 41-year-old man with type 2 diabetes who takes metformin and a once-weekly GLP-1, his A1C is 6.5. Or D, a 52-year-old woman with type 2 diabetes who likes to travel and frequently misses doses, and her daily basal insulin is 8.2%. So clearly, A1C is not at goal, and she's traveling a lot. So here's your takeaways. Basal insulin remains an essential and effective glucose-lowering treatment for many patients with type 2 diabetes. PCCs manage most patients with type 2 diabetes in the U.S., including many who receive or are indicated to receive basal insulin therapy. Despite insulin's long history in treating diabetes, clinical inertia routinely occurs due to a variety of facts resulting in treatment delays and suboptimal glucose management. And that's on our side. But we can fix that and we can help the patients and make their life better by offering something like a once weekly insulin. Ultra-long acting once weekly insulins may soon be approved and provide an additional option for basal insulin therapy. Once weekly insulins may improve adherence and persistence, flexibility in administration time, and reduce glycemic variability compared to once daily basal insulins. Potential concerns with once weekly insulins may include challenges with dose calculations and concerns about hypoglycemia, which may be resolved as clinicians become more familiar with these insulin formulations. This is a resource toolkit for you. You can visit the website via the QR code to the right or the URL below for more information on this topic and to review the presentation. So you have an option to look at the slides. Within the resource toolkits, there are things that will help you in your practice with your patients. So please scan this URL code and please join us at this website for more information and to go back and look at some of the slides and some of the information that I presented to you today. And then to receive your certificate, please take the post survey using the QR code or the URL below. What primary care physicians need to know about once weekly insulins. Want to make sure that you get your take the survey so that you get your credit. And don't forget, you also can get 2 extra credits if you're willing to answer the questions about changes you want to make in your practice and giving us your name and your email. And then in about 6 weeks' time, we're going to ask you again what changes you made. And if you complete that form as well, you will get a certificate for 2 more credits. So you have the potential for 1 credit today and 2 credits in the future. I want to thank you for joining me today. It has been my pleasure to spend time with you and speak to you, and hope you'd enjoy this as much and that you start thinking about once weekly insulins, which I think will in fact improve the lives of people with type 2 diabetes. Thank you.